Good afternoon, everybody, and welcome to the GIRFT Endocrinology National Report webinar. My name's John Wass, and I, with Mark Lansdowne, led the visits to 127 hospitals in England, actually. And it's really good to be talking to everybody and working with everybody to improve the delivery of endocrinology and endocrine surgery care. I'd just like to begin by reminding you all that this will be recorded. And by way of an introduction, Mark Lansdowne, who came on some of the visits with me and did the report with me, is going to start the talk. Then that will be followed by John Newell-Price. Mark is an endocrine surgeon in Leeds. John Newell-Price is a physician in endocrinology in Sheffield, and he has very recently done a report with Christian Bollard for the Society for Endocrinology to improve endocrine practice. And a lot of the work and things that they suggest in that report accord with some of the things that we've done in the GIRFT report. After John Newell-Price, Radu Mihai will be talking. He's an endocrine surgeon and president of the BAETS, and he'll be talking about surgery. And then after that, there will be a discussion. And contributing to that are Antonia Brook, who is now head of the endocrine SAC at the College of Physicians, was involved in the Society for Endocrinology report and is herself a physician in Exeter. And then Helen Doran, who's an endocrine surgeon in Salford, is also going to contribute to the discussion from the surgical point of view. What we've decided is that we'll have questions and answers at the end. We may get a large number of questions, in which case, as soon as possible after this, we'll produce a document which answers those questions and which we can circulate to everybody on the webinar today. And we intend to answer all the questions by that means eventually, and we'll answer as many as we can today during the Q&A session during the webinar. Already after the report, we've published 3 papers, actually, one on thyroid, one on parathyroid, and one coming out on adrenal surgery. There is a huge importance attached to obesity services, and although we won't be talking about those today, they are only present in around 50% of the country's hospitals, and I think this is something which is an ongoing issue for those of us who look after patients with severe and complex obesity. And I think that it's also relevant that there's been a huge increase in demand in endocrine outpatients, 140%, and that's something which is over and above the increase in demand in general medicine. And so there are really issues in terms of many aspects of the delivery of our service, which we can and think we will improve in the due course. So now I'd like to hand over to Mark, who's going to give us a talk on some of the aspects of surgery. And then after that, it'll be John Newell-Price. So Mark, can you take over now, please? Thank you.
Next slide, please. The impact of the pandemic on our service has been very plain to see. We're seeing long delays to first appointments and subsequent tests. We've got probably tens of thousands of patients with delayed follow-up, and there's a risk that some of these patients will come to harm. We're also seeing longer waiting lists for surgery, and in some parts of the country pre-pandemic, patients waiting for surgery for Graves' disease were waiting for a year, and there's no doubt that that has definitely got worse over most of the country. And we know that some of these patients will come to harm, particularly those that have already started to develop problems with their eyes. But one positive thing that has come out of the pandemic, and that is new ways of working. And I'm going to move on to some of those now and how they line up with our reports. So to help a little, I've drawn up a couple of headings and I've put many of our recommendations under those headings to outline how we can use the GIRFT endocrinology report to help recovery of elective services. I'm going to talk mostly about optimizing patient pathways. John Newell-Price and Radu will talk a little bit more about the perhaps how the surgical outcomes can be improved. I'll talk a little bit at the end about the interface between surgeons and endocrinologists. Next slide. So, optimizing patient pathways. This was recommendation 9 in our report, that there should be triage and pre-investigation before seeing patients to improve patient flow and to address capacity challenges. And remember, this is pre-pandemic that we were recommending this. We felt that this should be supported by trusts, but that the Society for Endocrinology would be in an ideal position to help develop protocols for the implementation of this referral and assessment service and to support triage of patients. Next slide, please. Now, this falls in very nicely with work which is going on through NHS England. So most of you may be aware that there is now a national outpatient transformation program. There are regional teams to help with this as we move forward. They're looking at improving referral processes, and that is lined up with GPs. They're using NHSX to help with enabling care through technology. And there's also a lot of work going into patient-initiated follow-up and how that can be safely introduced. Specialty redesign is part of this, and the National Outpatient Transformation Programme team will work with individual specialties to bring this online. And endocrinology has been identified as a priority specialty to work with. And John and I have already started to engage with them, and we've got several more meetings coming up. Next slide, please. So I want to draw attention to this. It's well worth downloading and looking at. So this is a discussion document prepared by the Society for Endocrinology. They've worked very hard on this over the last few months. Some of it is based on the recommendations we've put in our report. A lot of it is based on good practice around the country and an attempt to roll this out generally throughout endocrinology. Next slide, please. So part of this is the e-referral service, or ERS as it's come to be known, and how it fits in with advice and guidance. You can see from our report that this is what we've been recommending, that we combine this with pre-investigation. Where should those investigations take place? Well, some of them clearly should be done in primary care before referral. But we're also now building up diagnostic hubs in the community, which gives us another resource. And many of the larger endocrinology services have access to an endocrinology day unit, and we need to think about how we can strengthen and build on those. Next slide, please. A couple of slides I borrowed from NHSX. For those of you who aren't familiar with the e-referral program, it replaced Choose in Book in 2015. It was moving along quite slowly around the country, but there was a definite pickup in use of this in 2021 during the pandemic. For those who don't know, all referrals into secondary care now are electronic. There are no longer paper referrals. All the fax machines have been turned off. Next slide, please. So this shows increase in requests for advice and guidance over the last few months. And what happens is that the GPs will authorize a request for advice and guidance. It can be converted to a consultation if clinically appropriate. And you'll see at the bottom right-hand corner that about a quarter of those that are approved for conversion are actually converted. Next slide, please. And this is the data for endocrinology. This is October, last month. Nearly 6,000 requests for advice and guidance, with 72% of those coming with pre-authorization to convert into a consultation. And of that 72%, 20% actually become a consultation. And I think this is showing how we can take a little bit of the burden off the front end of the outpatient department. Next slide, please. Now, advice and guidance is being rolled out. People are being encouraged to do it. It's not being enforced. It needs proper resourcing and job planning. We have to involve patients in this process, and we have to make sure that any patients in groups that don't have access to the technology are not disadvantaged. It works both ways. It allows for education back into general practice, and there's clearly work to be done on evaluating how effective it is and improving it over time. Next slide, please. So I'm just moving quickly to the other end of the outpatient journey, and that is, what is the most effective method of follow-up? If we think about tumour markers and screening, we only use them if they're effective. We think about how much they tell us with regard to the patient. Once we've got that extra information, does it signpost us to something useful we can do for the patient? And how cost effective is it? And we need to be thinking along these lines when we book a patient for follow-up. Instead of bringing them back to the clinic, will a letter, a phone call, or a virtual appointment suffice? And is there scope for patient-initiated follow-up? In our own practice in Leeds, Rob Murray's done a lot of work on this with our thyroid cancer follow-up, which is now stratified and also involves patient-initiated follow-up as well. Next slide, please. And finally, a little bit about endocrinologist and surgeon interface. Clearly, we work well as a team, and where that team works well, we work best. I think we can work together to agree what tests should be done before a patient is referred to the surgeon. As an endocrine surgeon, almost every patient I see is referred from an endocrinologist. I have had the occasional referral of a patient with hyperparathyroidism directly from a GP, but generally it comes from my colleagues in the endocrinology clinics. If you're an endocrinologist and you see a patient with primary hyperparathyroidism, do they need cross-sectional imaging? Talk about it with your surgeon, decide which patients need the imaging, because if a patient is not going to agree to see a surgeon, or if a patient is really not fit enough for surgery, they probably don't have any benefit from having those images. Does the patient need to see a surgeon before going on the waiting list? We have a lovely example from Hull, where the endocrinologist and the endocrine surgeon work so closely together that the endocrinologist will put patients with parathyroidectomy onto the waiting list, and the endocrine surgeon can look back at the endocrinologist's letters, and in most cases will not need to see that patient until the day of surgery, and that saves the patient and the whole system a lot of time. And then, if through advice and guidance you are referred a patient with a euthyroid goiter or a thyroid nodule that needs investigating to exclude cancer, please redirect those to a 2-week wait, one-stop neck lump clinic. That will speed up their processing. All those of us who do those clinics work very closely with our endocrinologists, and we've seen some evidence that neck lumps can stay in the system for a bit longer than necessary. At the moment, you cannot make an e-referral directly through to your endocrine surgeon in all trusts, but there are ways around that, and you should look for local solutions. Next slide, please. So some extra resources that you can look at, and I think John's going to be very pleased with me because I have definitely kept within the time allotted. Thank you very much.
Thank you very much, Mark. So next, it's John Newell Price talking. Thank you.
So thank you, John. Thank you, Mark, and thank to both of you and Ger for asking me to give this short talk. I'm going to be talking about pituitary and adrenal, and just considering what we need to do to improve and optimize services. But by way of introduction, it's worth, I think, just isolating what the prevalence of pituitary tumours are. So there are around about 800 per million population. And these data are actually drawn from the Banbury population, which John Wass and others published some 10 or so years ago. And you'll see that around half the patients have prolactinoma. So these are patients who are usually managed medically, but the other half are patients who will almost or often need pituitary surgery. And of those, some of them may be incredibly challenging, such as patients with Cushing's disease, challenges in both diagnosis and overall management. But I emphasize that hardly any of these are cancers. They are mostly benign tumors that cause problems because of local effects and effects of either too much or too little hormones. What about adrenal tumors? Well, there are some real challenges here. So I'm going to just show some CT scans. So here are some CT scans shown of different adrenal tumors. And the reason I show this is because on the far left, we have a benign adenoma, around about 16,000 per million. The vast majority of these need nothing to be done. Here, looking not dissimilar, is a pheochromocytoma, 2 to 8 per million, high mortality if they're not recognized and treated, needs an expert medical team, expert anesthetic team, and an expert surgeon to make sure that they're handled correctly. Here, this next one, which is rather unpleasant looking, is in fact an entirely benign myelolipoma, usually needs no intervention. And finally, on the right-hand side, perhaps not looking so dissimilar, is a large adrenocortical cancer, about 1 per million population, highly malignant, and really the best prognosis is achieved by the patient getting to an expert surgeon in the shortest possible time, because these can be very aggressive tumors that metastasize early. So the GIRFT findings for pituitary and adrenal disease have demonstrated that there are delays in diagnosis, for example, particular delays in the diagnosis of patients with Cushing's, duplications of tests, that's from the referring centers to the referral centers, so tests are repeated and this delays patients being managed and of course costs more money. And there is a clear need for regional access for specialized procedures such as venous sampling done in the investigation of primary hyperaldosteronism and also in the investigations for ACTH-dependent Cushing's disease, that being petrosal sampling. And as Mark has already alluded to, there was delays in surgery during COVID, but there were delays in surgery pre-COVID. And one of the real aspects that's been highlighted is a very variable number of the actual surgical volume. And there are low volume surgical practice in both adrenal and pituitary that I'm going to illustrate on the next 2 slides. So here is a figure taken from the GIRFT report illustrating that in the light blue, these are the percentage of surgeon in a 2-year period taking or performing rather only 1 procedure in a 2-year period. And here in the darker blue are surgeons performing fewer than 5 procedures in a 2-year period. So this is of all adrenalectomies, of cancer adrenalectomies, and of patients with pheochromocytomas. And the recommendation from GIRFT is that the low volume surgery ceases, and Radu will be speaking to that in more detail. What about pituitary disease? Well, here are the total number of pituitary excisions by trust. Again, this is over a 1-year period shown from HES data. And you'll see that there are some very high volume centers, but there's a long tail of low volume centers. And again, we recognize that outcomes are poorer in low volume centers. So the GIRFT recommendations for pituitary and adrenal surgery I've highlighted here and taken directly from the report, and they are that centers carrying out very few adrenalectomies should stop doing so, and that the centers should refer their patients on to surgeons within a network who perform higher volumes, and similar recommendations made for pituitary surgery. And in addition to that, that really the endocrine departments across the region work together to solve the issue of some of these complex investigations that require things like venous sampling. And the solutions that GIRFT put in place, and this was pre-pandemic, was that there should be networks of endocrine care. And I've highlighted in yellow the various recommendations made in the GIRFT report suggesting that these networks be set up, that they be run, that there is appropriate administration, and that there's active agreements between trusts to all make it work. So that was everything that was being recommended, and then this thing hit. And of course, this has had a huge impact on all of our lives, mainly in a negative way, but there have been some potential positives. And one of the positives is that, if anything, regional working, I would argue, is now probably better than before. So certainly on our own patch, our regional MDTs have teams link in, and we have clinicians from a very wide geographical area able to link into the MDT electronically. And that really has changed things and made it much better. We were doing it to a certain extent pre-COVID, but are doing it to a much greater extent now. And in addition to that, the ability to be able to have online education and training without the need for people to travel has made a big difference. Of course, it takes away some of the personal interface, but certainly there are advantages. And it was in light of considering how to really leverage some of these changes that the Society for Endocrinology set up the working group on the future of endocrinology. And I list the people involved here, and on the right-hand map, you can see the wide geographical diversity and the diversity in the members on the working group who actually have written the report, which has been alluded to. And I see that Ian Russell has put in the chat function the link which allows you to gain access to this report. And this report has to a certain extent answered, or at least sought to answer, some of the challenges put by GIRFT in how to manage the patients with endocrine disease going forward. And I'd commend you to read it, and we'd be very interested in your feedback. So thinking about the networks, the recommendation here from GIRFT is that trusts establish some service level agreements to make sure that patients with adrenal disease and pituitary disease actually are managed in a network fashion. But the question is, how do you actually do that? How do you actually set about doing that? Well, fortunately, I think we've got a pretty good model already, and these are the ENET centres of excellence that exist. So the UK is incredibly well served already for neuroendocrine tumours. 13 out of the 62, or 20% of all European centres, are in the UK. And these are centres that have been set up, and the centres have to work with trusts and set up service level agreements, talk to the referrers, make sure there's open pathways, make sure the patients are being managed in a dedicated network fashion where everyone is part of that network. It's a huge amount of work, but actually it results in far better patient care. The data are audited on a yearly basis and are reaccredited on a 5-yearly basis. And this means that there is a quality assurance that there is ongoing care to the highest standards for these patients with very complex disease. And one can imagine that analogous types of programs could be set up for both pituitary and adrenal in more detail and depth perhaps than being done at the moment. And finally, I just want to put it that we have to consider a lot of this beyond what will become the integrated care system. So here on my own patch is the integrated care system for South Yorkshire, covering around about 1.5 million population. We already receive from a greater distance and a greater number of patients for our pituitary and adrenal service. And for adrenal cancer, of course, with a prevalence of around about, or incidence rather, of around about 1 per million, there really does need to be some consideration for how these patients should be managed on a nationwide basis. And a survey of the patients has demonstrated that they are very happy to travel as far as necessary. And there are complex diagnoses such as the venous vein sampling, and one needs to have a dialogue beyond just the ICSs for some of these more complex and rarer conditions. And the proposal would be to have regional visits involving GIRFT, the Society for Endocrinology, the CRGs, etc., to really question how the structure can be put in place to truly try and manage these patients in a better fashion. And with that, I will stop sharing and hand over to Radu. Thank you.
Thank you, John. Radu?
Hello, good afternoon. John is okay? You can see me?
It's fine, thank you.
Thank you very much for the invitation to talk. I was given a strict title, that is volume outcome relationship for thyroid, parathyroid, and adrenal surgery, and how this impacts on the need for more accurate national databases. So based on the recent report, the need to submit cases to the national audit maintained by the British Association of Endocrine Surgeons, it's likely to become a trust-based responsibility, and how everybody captures the data in the audit but is yet to be there, be the responsibility of individual trust as much as of the clinicians involved in the care of such patients. So what is this BATS audit? It's a national database that was created over 2 decades ago. When I joined the BATS, it used to be a piece of paper that you sent through a fax over to the College of Surgeons. Now it's a web-based platform that has a record of over 130,000 operations done in these 20 years. A recent report that I was co-author of shows that every year we record about 7,000 thyroid operations, maybe 3,000 plus parathyroid operations, and somewhere about 500-600 adrenal operations. And this is a progression of the number of cases every year recorded on this audit. These are the surgeons now, probably about 200 doing thyroid surgery down to 40 doing adrenal surgery. So it's a wide representation across the country, but it's not perfect. It's not perfect because some 16% of the data fields, it fails to be completed, and we have a whole process in place to try to improve on that. And the lack of submission applies to surgeons with different workload across all type of operations. But more importantly, is the concern that this audit doesn't capture all the activity done outside the British Association of Endocrine Surgeons members. So to look at this, I got help from Professor Neil Tolley in London to compare how much was recorded in the UK Reds in blue bars and how much in fact appeared registered on HES database over a 3 years period. And if we look at the percentage, it looks like maybe 3/4 of the thyroid work is recorded, maybe close to 80% of the parathyroid work is recorded, but down to 40% for the adrenal surgery. And that's because each of these operations is done by many people outside the BATS. For the thyroid and parathyroid, ENT surgeons are involved more and more, and many of them are members of BATS by now, and many of them contribute to the audit already, and this work started good many years back. For adrenal, it's likely, but is not proven, that a lot of the work is done by urology surgeons or general surgeons or surgeons from other specialties that have nothing to interact with the BATS. And this is not only their personal limitation in the way they run their practice, but it's a reflection of the referral patterns from the 125 endocrinology departments that each of them has to decide to whom to send patients that they think would need surgery. So a lot of the discussions we have take place between people working in big units where there is a large number of endocrinologists, a huge number of surgeons from whom to choose. And so a clinician, a medical endocrinologist will have a choice of surgeons to refer to. But in smaller units might not be the case, and whether to keep local hospital or refer to neighborhood bigger unit, it's not an easy work pattern that many clinicians have at this point. To look further into the adrenal surgery, again, into that 3 years period, we were missing so many operations done outside the audit. So I looked at the distribution of how many operations are in across the units. HES records over 130 units having done adrenal surgery. And I looked at the top ones with the highest workload, and it appears that based on HES data, some of them do 100 plus 200 operations, of which hardly any were recorded on the audit. So it's not just that the small units don't do well, the big units can do just as bad as everybody else, and each of us has space to improve on the way we record all of these. And it's very important because there is a trend that we can learn when we look at this. First of all, was mentioned earlier that too many people don't do a minimum number of cases per year. So even within the BATS membership, only 16 members recorded more than 12 cases per year on average over the 5 years analysis of the audit. And there were 25 who reported less than 6 per year. Maybe they did more. We don't know that. The data is not cross-checked with the HES reports, but certainly they've not registered more than 6 per year on average over 5 years. And maybe for some cases, this is not such a significant issue, but for surgery for adrenocortical cancer, as we heard in the earlier presentation, the concerns are really grave for the patient. I don't think there is any other malignant diagnosis in this country for whom to be happy to report that only one surgeon across the whole UK does more than one case per year within 5 years audit period. These patients are diluted over too many units. For most of those units, such a patient will be the one and only done over a good many years, and patients of different specialties get involved because they get involved. And so far, there's never been a mechanism to stop that from happening. Because this is a condition with such high mortality, and the impact of the diagnostic pathway and the surgical treatment is so significant, it's very easy to start from here and build up towards the pheochromocytoma. Dutch renal surgery. There is no doubt that there is a volume outcome correlation. It's been published on many publications. I will list only a few. Recently, the UKREDS data was used to show that the complications of permanent hypoparathyroidism and nerve palsy are lower when patients are operated in units that do at least 50 cases per year. And previously, Neil Tolley showed a gain of 70,000 operations analyzed from HES that surgeons with volumes over 50 per year achieve lower complication rates and lower short of stay. Most recently, Mark Lansdowne used the HES data to come up with the same conclusion, looking at length of stay when analyzing 22,000 such operations and showing there is a trend to decrease the length of stay once you reach about 50 to 60 per year. Same happened with the adrenal surgery. Once again, an excellent paper by Professor Woss and Mark Lansdowne looking at the 4,000 adrenalectomies analyzed and reporting, as expected, that only a third of the surgeons did more than 6 cases per year, and that there is a clear impact on the probability of emergency readmission based on your workload. It's not easy to find an easy marker because mortality is not an issue. This is not cardiac surgery where we can compare people based on in-hospital mortality. We don't have yet a parameter. We don't know what are the patient-reported outcomes. We don't know the functional outcome in the long term. So the surrogate for quality, it's still length of stay, that potentially it's affected by many social factors in different regions of the country rather than by the quality of surgery. What happens in the UK is not unique. Across Europe, it's a similar process put in place. In 2019, the European Society of Endocrine Surgeons had a conference based on volume outcome correlation, and papers were published for thyroid surgery recommending that only centers doing more than 100 cases per year should do thyroid cancer surgery. That is not feasible in the UK because of the workload being lower and the distribution of work, but it's very feasible for Germany, for example. For parathyroids, the advice is to everybody to do at least 15 per year. Again, not an easy to come up with the number. GERF suggested 20 per year. And that the challenging procedures of familial disease or patients with negative scans and not localized, and certainly the children with primary hyperparathyroidism should go to center doing at least 40 per year. And then a final publication on adrenal surgery that I was main author, we came up with similar numbers saying that at least 6 per year to do any adrenal surgery, and 12 at a minimum towards 20 if you are to do adrenal cancer surgery, and emphasizing the need for an established MDT infrastructure. And my personal criticism is that an MDT is not just a group of people that decide to walk into a room from different specialties. It should be a group of people who have exposure to that condition before a debate of a new case happened. Otherwise, if this is the only case treated over the last 5 years, nobody can value much the comments that come into such an MDT interaction. So to cut it short, I would say that UKREDS remains the only national audit database. No other specialty has a mechanism to pool national data. Despite this, there is a significant proportion of work done by surgeons who don't contribute to this audit platform. And that's against the current decision of the BATS to encourage members, people who are not members of the society, to register to use the audit. So you don't have to be a BATS member in order to have access to this online audit platform. I think no change will come until data reporting would be a professional standard assessed in your annual appraisal, and that each trust will need to be made responsible to monitor compliance with this. Otherwise, one by one, people doing one case or 5 cases will stay under the radar, and us as a society, a professional group, will have little control over what happens in each institution of the country. And I think the most important is the collaboration with the ENT group and with the urology group if we are to have a good implementation of these recommendations. The BATS has approached both these professional groups. The ENT colleagues have agreed a common program for national meetings. I'm still waiting for the Urology Society to reply to a similar invitation to explain why audit is important and how this data collection could shape the practice, because otherwise we can meet like now and we claim you need to do 20 parathyroids, but we can't prove that those doing at least 20 are any better than one who does 5. And without big national data collection, this will be impossible to demonstrate. So I would stop here and I hope to take some questions.
Thank you, Radu. Mark, you're going to chair the questions.
Yes, I'm going to start off with a question for Radu that has come up here. Radu, it says here, does GIRFT have a plan with BATS to encourage Department of Health to mandate participation in key national audits? Do you want to elaborate a bit on that? Our audit is recognised by HQIP as the audit in which all this information should be held. The question is enforcement, isn't it? And like
indeed, because encouragement, it's a very vague word. We have encouraged people to do that for the last 20 years when this was established, and you've seen there was a slight increase in the number of people reporting cases, but this has plateaued over the last 10 years. And a part of newly appointed BATS members in new jobs, the involvement of other specialties has been flat zero so far. So we now opened it to people that are not BATS members, but until it becomes enforced at each institution level rather than through generic countrywide encouragement, I don't think it will happen.
Mark, do you want to say something about the meeting that we had amongst the different colleges of surgeons in terms of trying to improve the actual submission to audit as part of the appraisal process?
Yes, and it's very clear that not only the colleges, the GMC would like to see better audits. Ultimately, I think this has to be addressed through the appraisal process and by individual trusts and their medical directors. I'm going to just move on and ask Antonia a question, if I may, please. The Society for Endocrinology has a process of peer review, and there's some similarities in that with what we've been doing in GIRFT. Would you like to tell us a little bit more about that process and how this bottom-up approach is the best way to lead to improvements in clinical care?
Thanks, Mark. I don't think it's the best approach, but I think it's a collaborative approach with everyone else. And I think that the GIRFT report and the CRG and the working group for the future of endocrinology gives us lots of tools. And really the purpose of peer review and the society is how we can get those tools into practice. So, you know, we're looking at doing many more sort of miniature reviews, looking at some qualitative things, really straightforward things. One of the big things was how to get more endocrine specialist nurses in, looking at, you know, giving people job plans for that, trying to encourage a really good working relationship so those nurses are used well, things like that. And then in addition to that, as part of the outcomes for the working group, there's also going to be portals on the Society for Endocrinology website to share information, use best practice. We can go into centres and help them to establish some of these working practices. And the same is true of education, that we're going to try and network better across the centres so that trainees coming through are entering their consultants years with the best view of how to move it forward.
Thank you very much. Helen, in our report, during the time between when John and I wrote the report and then when it was actually agreed for release, we changed our mind a little bit on day case thyroid surgery to line up with the recommendation from Bates, and you were, I think, really instrumental in that work with Bates. Would like just to say a few words about day case thyroid surgery, how appropriate it is, any safety things we need to consider if that gets rolled out more generally?
Yes, thanks, Mark. So BATS actually changed its endorsement of, previously we didn't endorse day case thyroid surgery. And after a period of different projects, we decided to endorse selective day case hemithyroidectomy. So that's not that every patient who has a hemithyroidectomy requirement should have it done as a day case. It's just that patients who are deemed to be low risk can go forward and have that done. And actually it's come up as one of the GIRF recommendations. So recommendation number 5 was that 90% of cases, parathyroid cases, should be done as a day case, and 90% of thyroid lobectomies is a maximum of 1 night stay. But it's really important that people recognise that we're only talking about suitable cases here, because not all patients will be suitable for various different reasons. And what we did show with the UK RETS data, so we took the audit that Radu's mentioned, the audit data, we looked at 24,000 hemithyroidectomy cases, and we showed that actually the incidence of bleeding is really low and the incidence of mortality is extremely low. And so if patients are correctly chosen, they can go forward for safe day case hemithyroidectomy. And I think where the GIRF process probably rolls into this is that it's to do with making sure that you've got the right surgeons doing the operation. So this is people who are doing regular cases. And we did show in our paper that surgeons who were doing more than 4 cases, that's less than 1 a month, more than 4 a week, more than 4 cases actually had a 1/3 lower incidence of bleeding. And it's also that the protocols are embedded. Now, we didn't look at that in terms of UK RETS data, but when the GIRF process went and talked to various units, it was clear that people didn't have clear follow-up protocols about how to manage thyroid bleeds. And what you don't want to be doing is having patients turning up at places where that can't be managed, who are done as day cases. So it's choosing which patients are suitable, who should be doing and where the operation should be done, but also making sure that you've got clear protocols in place for when patients do unfortunately have complications and turn up in the right units for it. And these networks that we've talked about may well help with that.
Yeah, I think we're seeing a little bit of a theme here. I think we're perhaps asking our endocrinology colleagues to give a little bit more thought to which surgeons they refer patients to. Now, here's one for the endocrinologists on the panel. It's one that's very close to my heart. I suspect this has come from a patient. It's a question from Sally Powell. She says, many endocrinologists are not referring patients with for parathyroidectomy. They're in favour of prolonged watch and wait processes, which can go on for many years, have devastating health consequences, and so on, as we all know. So a few years ago, one of my uncles had a parathyroid adenoma, and his endocrinologist told him he didn't believe in parathyroidectomy. He felt it was no advantage to have your parathyroid removed. And when I suggested in a letter to him that he might like to refer him to one of my colleagues in Manchester, he threatened me with the GMC for interfering in my uncle's care. So is this something that John and Antonia recognise in your peer review process as you go around the country, is referral for parathyroidectomy standardised? Do people follow the NICE guidelines?
I must say, I think that's very interesting, because yesterday I saw an 81-year-old woman who'd seen 2 endocrinologists, who came in with her son, who was very fatigued and actually unclear that she should have a parathyroidectomy. The parathyroid adenoma had been located and that had been refused by 2 previous endocrinologists as she'd seen. So that's only an anecdote, but it accords with yours, Mark. And I think that a lot of endocrinologists are using parathyroidectomy much more than they used to be. The trouble is that we've been trying to set up a study looking at mild hyperparathyroidism and its effect on cardiovascular systems, on arterial elasticity, and so on and so forth. But it hasn't gone forward, unfortunately, over many years. So I think the scientific data are not as good as they should be. But that's certainly my view, that most patients with hypercalcemia get referred for parathyroidectomy by my friend and colleague, Radu. John and Antonia will have views as well.
But from a smaller hospital point of view, there are guidelines that I think most people follow. John will know that I think in the GIRFT reports, the number of renal ultrasounds being done looking for renal stones was perhaps lower than it might have been. And for those that live in areas of the country with a very elderly population, relying on things like osteoporosis as a consequence of hyperparathyroidism is perhaps not that useful. So there's other things that we would consider. I think there's some new guidance coming up that's got a much softer focus towards parathyroidectomy as well. And if they get adopted to any degree, then it's likely there'll be an increased referral towards parathyroidectomies, I imagine.
Yeah.
Right. I've got a question here, which I'll probably have to answer myself. It's about how did we choose the numbers that we would say are recommended that surgeons should do for parathyroidectomy. In this country, there's never previously been a recommendation of number of cases. We've based our recommendation, we think is a pragmatic one, it's based on outcomes that we've seen in HES, and they are in the paper that John and I have submitted for publication. Some of that information is in an abstract from a Bates presentation, but that paper has not yet been accepted, so I can't go into all the details around it. It differs slightly from the European one. Radu, you're probably more aware of the European recommendation of numbers than I am. I think they've done pretty much the same, haven't they? They've looked at the data in their database and they've put a cutoff where they think that should be.
Indeed, that's why that's how they came up with 15 parathyroidectomies at the time, looking at distribution, looking at top quartile surgeons, and seeing in big national databases how you prove a correlation between these, because you cannot extrapolate data from a few reports from center with huge practice and then claim that everybody should be at that point. That will not happen. You need to allow clinicians to reorganize practice, but not to have most people threaten that their practice will disappear.
And from the HES data, looking at parathyroid and thyroid, we have not shown the maximum number per year that gives you the best outcomes. It gets better if you do 20, 30 is better, 40 is better than that, 80 is better than 40. There's so few people doing 100 and more, you start to get too big an error bar to be able to say that doing 100 is better than 80. But there's a hint that it is. But as a, you know, statistically, we cannot say that with certainty. A question here from Salman Razvi. How much strength does a GIRFT report and its recommendations carry? Do trusts have a duty to follow these? The recommendation to have an endocrine nurse in each hospital is very welcome, but financial pressures are usually the reason if this isn't taken up. John, do you want to answer that? I'll help out a little bit if you want.
So I think that the GIRFT recommendations are strong. And I think that actually most of the endocrinologists want to implement them as far as they possibly can, so that already large numbers of changes have happened in pituitary surgery. There's a more increased number of lead surgeons in each of the neurosurgical units. There are other aspects of adrenal surgery and so on that I think are already happening. So that I think that GIRFT, the reports are strong, and I take the view that most endocrinologists and endocrine surgeons want actually to improve the situation. And so that's, I think, where I would be coming from.
It's possible that this will be improved with networking of endocrine services within ICS templates and possibly through commissioning as well. But at the moment, a lot of it has got to be peer pressure.
Can I just add that, again, that's where peer review can be very helpful, and the cost effectiveness, I think, of an endocrine specialist nurse can be far cheaper than a consultant if they're trained up to be able to deliver some of the care that's currently being delivered by consultants.
I think also actually that when I've gone round, I've actually written to departments and things as the chair of the GIRFT review, trying to emphasize how important it is and how actually it can save money and improve care. And I think that there have been some moderate successes when some of those letters have gone off up and down the country. And I sense that there are many more endocrine specialist nurses than there were, because they can deliver outpatient clinics and so on. So I'm very happy still to write to trusts and to endocrine leads who may need or think they need an endocrine specialist nurse, because I think there's no doubt at all that they improve care and that they save money.
I've got a question from Kath Bell. It says, will the 42 ICSs be able to refer outside their area to access the best surgical outcomes for all endocrinology? Well, I think most of us on the panel would hope that within each ICS, for the majority of endocrine surgery, the standard will be equivalent across all ICSs. I think the one possible exception to that, and John Newell-Price, I think, agrees with this, and that is adrenal cortical cancer. We probably do not need a centre in all 42 ICSs doing adrenal cortical cancer. I think we probably need, regional or even supra-regional centres for that. But I think we need to focus also on earlier diagnosis in that condition, because the earlier the diagnosis, the better the outcomes, because you need an R0 surgical resection. There is no other effective treatment. So within ICSs, I think a lot of work can be done on that. So I'm just flicking through the questions.
Can I just make a comment, Mark, that one of the problems with the adrenal cortical cancer, though, is that it's not always possible to know from the outset that you are dealing with an adrenal cortical cancer. And so the problem is that you then end up flooding your adrenal service with, I mean, obviously at the radiology side, a lot of patients could be taken out of the equation, but you're still going to have your indeterminate lesions of 6 centimetres in size. So which of ones those need to go to a centre who could potentially be an ACC?
Yeah, a little bit like the thyroid and parathyroid, we sometimes get a surprise.
So, but there would be patients that are deemed to have not be able to be offered surgical treatment, and those should be discussed once more with one of the supra-regional centers where maybe the expertise is different. I'm very grateful we had patients referred from a long distance to travel that ended up being operated with cardiac surgeons, with liver surgeons, 3 or 4 surgeons in the room, and that's not easy to put together in any single institution of the land. So I'm very grateful to those who use that initiative on a personal basis. If this could be made more formal, even better. But I think the mechanism for these unusual severe cases exists and has worked very well.
And so perhaps
John, John wants to come in, and I'd also like to ask you, John, about the new biochemistry of investigating these adrenal lesions.
So I think that these points about adrenal cancer are very well made and are fully agreed. In fact, the Society of Endocrinology has now got another project going on trying to look at and solve the issue with adrenal cortical cancer, and we'll be getting the appropriate stakeholders involved around that. In answer to the question about how does one know whether it's malignant in the first place? Well, that's why I showed those CT scans, because you need expert radiology, and they can vary greatly, and we get a huge number of referrals. But the point is, you're going to have expert radiology. In terms of the biochemistry, Vibke out in Birmingham and others have led on steroid-metabolomic profiling. That will make a big difference. And when combines the clinical features, the imaging features, the metabolomic profile, then you can start to really tease out which of these patients have a cancers and which don't. So I think there are moves afoot and things to improve things. And this is also being handled on a European level, because there is a European cost initiative at the moment looking at adrenal cancer specifically. So I think there's a lot of things moving in the same areas, but the direction of travel would be to try and make sure that you have the appropriate expertise in larger volume places.
Two more quick questions, I think, before we finish. One is, what is the current minimum number of thyroid operations per surgeon per year? It has been 20 for many years, but John and I, from the data we've seen, think it should be more than that. Probably we should be working towards 30 and then 50. And then, are there any resources to help those looking at setting up local endocrine networks? Well, we did mention that Society for Endocrinology and GIRFT hope to start doing network level reviews, where we will encourage providers, that is the trusts, to work collaboratively to do this. And we hope that ICSs and their provider collaboratives will invest in developing this type of networking, not just for endocrinology, but across all specialties. So I'm going to draw the questions to a close there. And I believe I'm passing back to you, John Wass, for a summing up.
Thank you very much, Mark. Well, the questions that haven't been answered, we will assimilate and send round to the participants an answer, so that we can engage in dialogue in the near future, which I think is very important that everybody feels joined up. And I think the whole process of the GIRFT report, the Society for Endocrinology and peer review, and the CRG need to keep working very closely together, so we actually evolve the recommendations that we've all been putting, because we're singing very much from the same hymn sheets. I think we need to work together with the urologists and the ENT surgeons to make sure that the data for audit of all surgery is put together, and I think we have some more work to do there. I think we need to make sure that the findings that we have, and I talked about this in Edinburgh, are disseminated to people who may not easily gain access to these things, to make sure that they happen. As Mark and John Newell Price and others have said, I think we have network visits to do, and I've talked to Tim Briggs about this, who's very protagonistic to the idea, and we're shortly going to be having a meeting to actually set this up, so that joint with GIRFT and the Society for Endocrinology, we get network visits in the adrenal and the pituitary. And then lastly, I think we need to make sure that we re-audit things. I think already that things are changing for the better, but I think we need to re-audit and have documentation that things are indeed doing that going forward. So thank you all for coming today. I hope it's been useful, and you'll be hearing from us. Bye-bye.